Thank everybody here for coming, and I would like to really thank all the distinguished visitors and speakers that we agreed to come to honor us with your presence and your very, very excellent talks. Thank you very much. We're waiting for the top 15 yet. Now I'm looking at we got two English speakers that were organizing the meeting with us, and they sent me with the first question that probably most of you have asked and you're too shy to ask now. So I'll raise this question, the answer to that question. Who knows what Scourge is? Anyway, so for those of you who are not familiar with that word, that was the first question I had to answer. So Scourge is a whip, sort of punishment or agony. Suffering in Hebrew it would be a shot, So is it really? And it is, of course. We know that from first study that examined that was the Sir Abramson and colleagues published in Annals of Internal Medicine in 1992. And he showed that among almost 100 patients that were visiting the clinic regularly, not for acute heart failure, he realized that about 28 of those patients had elevated pressures, pulmonary pressures, and among them 57% died during a follow-up of 28 months, relative to only 17% of those patients that did not have pulmonary hypertension. So this is a real problem, and this was further studied later on. The study by Dr. Aronson here with us today about the pulmonary hypertension and heart failure, the prognosis of those patients. You can clearly see that patients with no pulmonary hypertension fare much better than those with passive or reactive pulmonary hypertension, which we'll further elaborate later on. In a study that studied the effects of echo, a way to assess those patients in a simple way, but with using the echocardiography with the pulmonary systolic pressure and the TAPSE, the first studied by the tricuspid speed, and the second with the TAPSE, the function of the right ventricle. You could see that patients who had neither of those had a better prognosis than those who had both of them. And so this is another study that actually confirmed what we already see and know from clinical practice, that those patients with hypertension and acute heart failure fare much worse than those without. So let's start with the very beginning. There's this joke I was always trying to say, start the talk with a small joke about somebody seeing with a psychiatrist, and he asks him, what's your problem? He says, you want to start from the beginning? Yes, from the very beginning. Okay, so in the first day I created the earth and the sky. And so, well, I'm not going to go that further back, but then again, in the normal cardiac cycle, if there is any elevation in any of the end-diastolic pressures, either in the left ventricle or the right ventricle, the pressures go up in the arteries that are, in the arteria that supplies blood to those ventricles, and eventually the pressure goes back. The first one to study that was William Harvey in a book published in 1628. He said the right ventricle may be said to be made for the sake of transmitting blood to the lungs, not for nourishing them. So that was quite clever of him, quite nice to realize that on one hand. But then on the other hand, it sort of says that right ventricle, the importance of the right ventricle is reduced compared to the importance of the left ventricle. And we know that there are many patients that might live with a very, very malfunction of the right ventricle without right ventricle in physiology of patients, other similar patients that we commonly see with the dysplasia of the right ventricle, in which the function of the right ventricle is very, very reduced, and still if they don't have pulmonary hypertension, they fare quite good. So we sort of divide in our own recently published the way to assess the right heart failure. So you can divide that into three portions. Preload, if the patient is with excessive fluid overload, you would see that the right ventricle fails. And if you reduce the volume, you can see that what looks like very severe tricuspid regurgitation, you reduce the volume, this regurgitation goes down. The right ventricle failure with RV itself, or the afterward, the pulmonary hypertension, if you get pulmonary hypertension too high, you get right heart failure. So those are the normal pressures. I won't go back into them. Look in the right atrium, 0 to 8 millimeters of mercury, and the RV between 15 and 30 systolic and up to 8 diastolic. The PA, the same systolic and diastolic of 4 to 12. The wedge pressure about 1 to 10, same as the left atrium, and left ventricle 100 and 140 systolic and until 12 diastolic, and the aorta, what is in the aorta. Now, what happens when, for that reason or the other, the pressure, the end-diastolic pressure in the left ventricle increases, either because systolic dysfunction or diastolic dysfunction, valvular disease, either aortic or mitral, and diastolic pressure increases. As a result of that, the pressure elevates in left atrium, which causes pulmonary venous hypertension, passes transmission of that pressure to interstitial edema, causing pulmonary artery vasoconstriction, and if this procedure is prolonged, pulmonary vascular changes with pulmonary artery hypertension, right ventricular hypertrophy followed by RV dilatation, then tricuspid regurgitation is raised and the artery pressure is raised, and you get congestion. In the following minutes, I will talk about the prevalence, definition, pathophysiology, clinical significance of therapy for pulmonary hypertension and acute heart failure. So we've done a great job in treating patients with chronic heart failure. We managed to prolong the prognosis very nicely, and with the 3 medications that we found out only about 20 years ago. And since then, we haven't done much of a progress. We did not cure those patients. We delayed the progression of their disease. They come back and forth to the hospital again, and now they look different. They're not the same patients as where we used to see them in the beginning. They come now, as we saw in the previous discussions of Dr. Delgado. We see that those patients come with a lot of comorbidities. They got diabetes, they got peripheral vascular disease, the renal failure, liver dysfunction. They come with low cardiac output state. They come with catabolic metabolism, cardiac cachexia. They've got coagulopathies, they've got anemia, and most of them, very much of them, suffer from pulmonary hypertension. I mean, in those studies, the prevalence of pulmonary hypertension was seen in those studies very high. Between 25 to 75% of the patients hospitalized with acute heart failure have pulmonary hypertension. So this syndrome or this phenomenon is very, very common. Those patients that we've seen before are hospitalized, and among those who are released from the hospital, 50% of them are re-hospitalized again. So we see those patients in 1 year, 50% of those patients that were hospitalized will be hospitalized again, with 25 to 75% of them with pulmonary hypertension. So we're talking about a large number of patients. What is the common pathway of those patients? They start with elevation of pulmonary pressures. There's a gradual worsening of the right ventricle, a combination of low perfusion, left failure, and congestion of the RV failure. Get low cardiac output, low blood pressure, intolerance to drugs. You start reducing the doses of the medications you gave before. They develop malabsorption with cardiac cachexia, multi-organ failure, with extreme agonizing weakness, and then they die. Now, they had the classification of pulmonary hypertension published in 2009, widely used. You see all sorts of reasons, causes, and classes of pulmonary hypertension. Each one of those huge rectangles consists of only a small amount of patients. Sorry for that. How can I go back? And if you want to, can I get 2 slides back, please? Thank you. And if you want to, actually the real amount, the big mass of patients with pulmonary hypertension are those patients with second class of pulmonary hypertension due to left heart disease, systolic, diastolic, or valvular disease. And the definition of that pulmonary hypertension would be wedge pressure above 15. All the others are with wedge pressure below 15 millimeters of mercury. Mean pulmonary artery pressure of about 25 by PA catheter measurement. Mean PA systolic pressure above 35 to 45 by echo with velocity of tricuspid regurgitation. Mild pulmonary hypertension would be defined as between 35 and 45 millimeters of mercury. Moderate will be from 46 to 60, and severe above 60 millimeters of mercury. Now, what the pathophysiology of that thing is, again, elevated in the left ventricle, then left atrium, and then elevated pressures, the pulmonary artery, diastolic and systolic pressures. This we would call the hydrostatic or passive component, meaning the acute effect of the elevation of the pressures in the left system causes backward transmission of that elevated pressure to the pulmonary vasculature, with pulmonary systolic pressure mildly correlating with the wedge pressure, quite close correlation with low transpulmonary gradient. And if this process is prolonged, you get pulmonary vasoconstriction and remodeling of the pulmonary vessels, with further increase in pulmonary pressures and loss of this reversibility in vasoreactive or reactive or fixed vasoconstriction remodeling with high transpulmonary gradient. So those are two components of pulmonary hypertension in patients with left heart system dysfunction. You can see here a nice graph, which I adopted from the very, very good paper of Georgiopoulou, I pronounced that more or less okay, and it just recently published in a very, very nice review in 2 parts. And that you can see that, okay, if we're talking about the pulmonary hypertension above 25 millimeters of mercury, by definition, anyway, if we're looking here, you can see all those others are quite small group of patients. This is a bigger group with a weight pressure above 15, post-capillary pulmonary hypertension, group 2, with a transpulmonary gradient. When it goes to the low transpulmonary gradient, we call it the passive pulmonary hypertension, proportional pulmonary hypertension, with PVR, low PVR, relatively low PVR, and therapy for those patients would be heart failure, improving the heart failure therapy to reduce the pulmonary wedge pressure, and this is expected to be reversible or responsible to the therapy. The other group of patients, this is impossible. Anyway, the other group of patients are those patients with the transpulmonary gradient which is above 15. Those patients with elevated PVR, we'd call them the active or reactive or mixed because they've got the 2 parts, also the passive and the reactive, and out of proportion pulmonary hypertension. And in those patients, if you give pulmonary therapy directed towards improvement in heart failure therapy, reducing the wedge pressure, you get, in some of the patients, you can get reduction in the transpulmonary gradient and reduction in the PVR. Looking at this pulmonary hypertension as a reversible, responsive pulmonary hypertension with a quick reversibility, in those patients, you can go as ones on the left side. Now, if these pressures don't go down, we consider this as being fixed or irreversible or responsive or refractory pulmonary hypertension, and the therapy for those patients would be advanced therapy, which is like LVADs or PDE5 inhibitors. We consider them as delayed hypersensitive reversibility. Now, just for example, you take a patient candidate for heart transplant, we perform right heart catheterization, we get a PVR below 3.5 units, so this is a good candidate for heart transplantation. If you get a PVR above 3.5 units, try to do some pharmacological testing, and with those tests, with those elements given, the nitroglycerin, prostaglandin, and NO, levosimendan when it is available. If you can reduce the PVR to below 3.5 units, then it becomes again a candidate for heart transplant. And if you cannot, you will go on the LVAD. And it's a nice work from the group in Austria showing that in those patients that they did put an LVAD in the patients with elevated PVR that could not respond to the medications we gave as a pharmacological testing, those patients between days and weeks reduced the pulmonary hypertension and became good candidates for heart transplant. The survival was as good as those patients with low PVR to begin with. Those are the pharmacological agents we use for testing reversibility, depending on each center's protocol. And then again, we were talking about the LVADs, trying to take this hypothesis to the practical arena. To those patients that we are treating patients with a fixed or non-responsive pulmonary hypertension, we think we want to put some LVAD in those patients, but then those are the LVADs. Dr. Medalion will speak about those devices a bit later. When you want to go to implant an LVAD, it's not so simple, and then again comes back the pulmonary hypertension, and the major risk predicting post-LVAD failure is the RV failure, and high perioperative morbidity and mortality in those patients that suffer from RV failure post-LVAD implantation. So we've got to be very, very crucial of the assessment of a preoperative RV function is very, very crucial. The preoperative prediction RI function after LVAD implantation is important for selection in the process of selection of patients and the patient's outcome. And some of those parameters we use are the preload of the right ventricle, meaning the PA pressure. And then we go on the afterload, preload we go to RA pressures, and afterload the PA pressures, and those together form the RV stroke work index, which means mean PA minus mean RA times cardiac index divided by heart rate. And if this number is above 450, in different centers 350 anyway, if this number is high enough, it means that the right ventricle is recoverable, although it looks quite bad in the echocardiography performed at that time. But anyway, selecting a patient for LVAD implantation also requires some sort of controllable pulmonary hypertension. And those patients with elevated pressures, if we want to consider heart transplantation, here again, fixed pulmonary hypertension increases mortality early and late after heart transplantation, and the hemodynamic parameters that predict post-heart transplant risk for RV failure and early death are pulmonary hypertension with elevated PVR and elevated TPG, with PA systolic pressure above 50 or 60 mm mercury, PVR above 3.5 to 5 Wood units, and TPG between 12 and 15. Above those, there is high risk of RV failure post-heart transplant implantation. So in those patients, as we said before, we try to implant the LVAD as a bridge to transplantation or give some medications. So how we treat those patients? This room trying to look hectic as it is for most of those patients. You could go with the European guidelines. You could go with those slides as we've seen before with hypoperfusion and congestion and treat those. So you have to do all those in order to improve the left ventricular function. But then many times you're left with pulmonary hypertension despite all that. And there are no really good randomized studies that have addressed this group of patients. And we still think that pulmonary hypertension should be a therapeutic target in this group of patients with heart failure and elevated pulmonary pressures. The big concern is with patients with high PVR that this high PVR is a protective adaptation to the LV failure. And if you take any agents that will cause atrial vasodilatation, they might worsen left-sided heart failure and cause congestion and trigger pulmonary edema. And whenever you come to a pulmonologist and say that you want to give any form of a pulmonary dilatation therapy to patients with elevated wedge pressure, he would argue and say that this is wrong and that it will cause pulmonary congestion and pulmonary edema to those patients. And there are many centers that believe that too. And we have big discussion with some centers are quite close to us in that regard. I don't think that the fear of flooding is based on any good experience, because we have lots of experience with treating patients with pulmonary hypertension, heart failure. We started that experience with treating patients with erectile dysfunction, giving them sildenafil, and the results were quite good regarding the erectile dysfunction, and we did not cause any flooding of the lungs. There was no pulmonary edema to those patients. And we had experience of giving sildenafil to patients with heart failure and pulmonary hypertension, more or less 100 patients. We saw worsening of dyspnea in quite a few, between 2 and 5 patients. So treatment of pulmonary hypertension and heart failure, you could use prostacyclin analogs. Now, prostacyclin analogs and endothelin antagonists in chronic heart failure had negative or neutral effect. Then we think that in those patients, the study selection of the population in the studies was not appropriate to the group of patients with acute heart failure. The effects of PDE5 are favorable, but those studies were still small studies, and it only rarely causes pulmonary hypertension or pulmonary edema. The first study that was published in 2007 by Lewis and colleagues, they gave sildenafil to patients with severe left ventricular dysfunction, and they found that this was well tolerated and the quality of life of those patients improved. So what would be the treatment of pulmonary hypertension and acute heart failure? We saw before vasodilators. Therapeutic interventions with balanced pulmonary and systemic vasodilator effect like nitrates or muriel-sig-wat, and inodilators with a combination of positive inotropic and vasodilating therapy like Mirinon or calcium sensitizers like levosimendan. The rationale in the use of inotropes and vasodilators is that they lower PVR they've got sustained inotropic effect, they increase the contractility in the cardiac output, they cause venous and pulmonary vasodilatation, they decrease the right and left heart filling pressures, and decrease systemic and peripheral and pulmonary vascular resistance. So the paradigm has been changing all the time, and what the paradigm is, those patients that come, like the patient described by Dr. Delgado this morning, those patients would be regarded as no option patients not a very long time ago, and now we do have devices to improve those patients. So we've got to consider that as an optional therapy. For those patients, we need to be able to bring the patient to get that new therapy. So to conclude, pulmonary hypertension is a heterogeneous entity with different causes. It causes increased pressures in the pulmonary circulation. It's a frequent consequence of left-sided heart failure. It is associated with worse outcomes, and this combination of elevated LV filling pressures, reactive pulmonary arterial vasoconstriction, and pulmonary vascular remodeling. In the treatment is optimize the heart failure therapy for those patients with arterial reduction, guided by swan catheter using intra-aortic balloon pump, maybe using an impeller, inotropes and vasodilators, anodilators, phosphodiesterase 5 inhibitors, and prostacyclin analogs. And just remember that they do consider that, I think, in our experience at least, in others too, therapy of pulmonary hypertension in heart failure patients rarely causes pulmonary edema. And I thank you for your attention.